The monitor flatlined at 11:43 in the morning, and nobody in that operating room moved. Not the scrub nurse, not the anesthesiologist, not the two attending surgeons who had been standing over that man's open chest for the past hour and 40 minutes. They all just stood there, hands suspended, watching the green line go flat across the screen like it had somewhere better to be. Nobody moved except Nina Lawson. She was 29 years old. She had been a surgical resident for 22 months, which in the world of cardiothoracic surgery means you are roughly the same rank as the mop in the corner. She had not slept in 31 hours. Her breakfast that morning had been a granola bar she found in her coat pocket from 4 days ago. She had $47 in her checking account, a rent notice on her apartment door she had not opened, and a spiral notebook filled with handwriting so small that the nurses sometimes asked if she was writing in code. She was not writing in code. She was working. The man on the table was named Arthur Pell. He was 54 years old. He had a wife named Carol who was currently sitting in a waiting room on the 3rd floor, holding a paper cup of cold coffee with both hands, watching the door. He had a daughter named Grace, who was 17, and who had driven herself to the hospital that morning because Carol could not drive when she was this afraid. Arthur Pell was a school bus driver. He had been doing the same route for 18 years. Every kid on that bus knew his name. He brought hard candy on Fridays. He had been brought in 4 days ago with an aortic dissection, which is already a serious enough thing to make experienced surgeons set down their coffee and think. But Arthur Pell's body had decided not to stop there. The imaging had revealed something that none of the 3 attendings who reviewed his file had seen before in a live patient: a congenital anomaly in the coronary arterial tree, meaning the blood vessels branching off his heart had grown in a pattern that did not match any standard map. It was not wrong exactly. It was just different. Different enough that the standard surgical approach would almost certainly result in cutting something that should not be cut, or missing something that absolutely had to be reached. The first attending who reviewed the file, a man named Dr. Grant Holloway, had spent 20 minutes studying the imaging and then walked out of the consultation room without saying anything to the 2 residents who were waiting for his guidance. He did not come back. The second attending, Dr. Clifford Marsh, had reviewed it the following morning. He had looked at it for a long time. Then he had said, quietly, to no one in particular, that this man was not going to survive the table. He said it the way people say things they have already decided are facts, and then he had moved on to his next case. The third attending had simply marked the file as awaiting specialist review and left it on the board. The file sat there for 6 days. It sat there because in a hospital that handles 40 surgical cases a week, a file that frightens experienced surgeons tends to get very quiet, very fast. Not because people do not care, because people are afraid, and fear in medicine sometimes looks like paperwork. Nina Lawson was not supposed to be anywhere near that file. She was supposed to be on the 4th floor, processing discharge summaries for post-surgical patients. It was the kind of work that gets assigned to residents when the senior staff wants them visible but not involved, like parking a car just close enough to the party that it feels like attending. She had done the discharge summaries in under 2 hours. Then she had gone to the surgical board and read every active file from top to bottom. The way she did every morning, she was not actively in a procedure, because she believed that if you only ever know what you are assigned to know, you will only ever be useful in exactly the ways you are expected to be useful. She did not want to be useful in expected ways. She had read Arthur Pell's file at 7:15 in the morning. She had read it again at 7:40. Then she had done something that none of the 3 attending surgeons had done. She had picked up the imaging printout and tilted it 45 degrees, because something about the branching pattern nagged at her in a way she could not immediately name. The way a song lyric gets stuck just below the surface of a thought and will not come up fully no matter how hard you reach for it. She stood there in the hallway outside the surgical board for a long time, holding a piece of paper at an angle, while the morning staff walked past her on either side. She was thinking about a paper she had read 8 months ago. Not in a hospital, not in a library, in her car, in a parking garage, at 2 in the morning. Because the hospital Wi-Fi did not reach the on-call room, and she had needed to read this paper enough to drive to a location where she could get a signal. It was a paper published 17 years ago in a European cardiothoracic journal, about a modified surgical approach to anomalous coronary branching in adult dissection patients. It had 2 authors. Neither of them was famous. The paper had been cited 11 times in 17 years, which in academic medicine means it exists at about the same level of visibility as a sticky note on the back of a filing cabinet. Nina Lawson had found it because she had a habit of following footnotes. She would read a paper, find a footnote that referenced something else, find that something else, follow its footnotes, and keep going until she ran out of internet or fell asleep. She called it tunneling. Most people called it a problem. She tilted the printout back to level. She went home that night, which is to say she went to her apartment for the first time in 2 days, changed her clothes, ate something she heated in a microwave without reading the instructions on the package, and found the paper. She read it again, slowly. The anomaly in Arthur Pell's coronary tree was not identical to the cases described in the paper, but the geometry was close enough. The branching pattern had the same left lateral bias, the same secondary bifurcation below the standard access point, the same reason the traditional posterior approach would fail. She knew what would work. She sat at her kitchen table with her spiral notebook and she wrote it out. Every step, the modified access route, the adjusted entry angle, the suture sequence that would give the cardiac team a longer working window. She drew diagrams. She wrote notes in the margins. She filled 4 pages, and then went back and added to all of them. Then she went back to the hospital and slept in the on-call room for 3 hours. In the morning, she presented her written plan to Dr. Clifford Marsh, the attending who had predicted Arthur Pell would not survive the table. She stood in his office doorway and held out the notebook and told him she thought she had found an approach that could work. Dr. Marsh was a careful, serious man who had been in cardiothoracic surgery for 19 years. He was not unkind. He read what she had written. He read it more carefully than she expected. He sat with it for a moment, and she thought, briefly, that something was about to happen. Then he looked up and said, "You're a second-year resident." Not, "Your math is wrong." Not, "This approach has been tried and failed." Not, "There is a flaw in the suture sequence." Just, "What you are." As though the number of months she had been in the building was a complete answer to everything she had just put on paper. She said, "Yes, sir. The patient is in room 7. She said it evenly, not with attitude, not with pleading, just as a statement of fact. A man was in room 7. His name was Arthur Pell. He drove a school bus. He brought candy on Fridays. He had a daughter named Grace, who had driven herself to the hospital because her mother could not function when she was this afraid. Marsh looked at the notebook one more time. Then he said he would pass the notes along. She thanked him and left. She did not know until later that when Dr. Marsh passed the notes along, he sent them to the chief of cardiothoracic surgery without her name on them. He sent 4 handwritten pages of surgical methodology that were not his, without a single word indicating where they had come from, or who had spent an evening and a car ride, and 8 months of footnote following to produce them. The chief of cardiothoracic surgery at Hargrove Medical Center was a man named Dr. Peter Vane. He had been in surgery for 41 years. He had trained under one of the most technically precise cardiac surgeons of the previous generation. He had a named suture variant used in 3 countries. He communicated largely through the precise angle of his posture and a vocabulary of single-syllable responses that his residents had spent years learning to decode. When Peter Vane said fine, it meant adequate. When he said good, it meant he would not mention the problem again. When he said nothing, it was usually the most important thing he had said all day. He read the notes that Dr. Marsh had sent. He read them twice. Then he called Dr. Marsh into his office and asked one question. "Who wrote this?" Dr. Marsh paused. It was a short pause, just one beat, maybe a second and a half. But Peter Vane had spent 41 years reading operating rooms, and a second and a half of hesitation, from a man who had not hesitated in any conversation, Vane could remember was enough. He already knew it was not Marsh. He did not say that. He waited. Dr. Marsh gave him a name. Peter Vane nodded once and said nothing further. Dr. Marsh left. Peter Vane sat in his office for a while after that. He looked at the 4 handwritten pages. He thought about the modified posterior approach described on page 2, and the suture sequence on page 3, and the footnote at the bottom of page 4, referencing a paper he had encountered a long time ago, a paper he had very nearly forgotten existed. Then he picked up a phone and made one call. He did not explain the call to anyone. He just made it. And 3 days later, when the surgical schedule was posted for the following morning, a name appeared in handwriting that was not the charge nurse's, added in blue marker at the bottom of the roster for OR3. Nina Lawson. Second assist. She saw it at 5:47 in the morning and stood in front of the board for a moment, without moving, reading her own name like it might mean something different on a second pass. It meant the same thing on the second pass. She went to scrub in. No one explained. No one called her. No one left a note or sent a message or pulled her aside to tell her what was happening or why. The hospital simply moved the way it always moved, fast and without ceremony, and she was somewhere different when it stopped. Arthur Pell was already on the table when she walked in. The room smelled of antiseptic and recycled air, and the particular kind of focused quiet that descends over a surgical team before the work begins. The lights were exactly what they always were. The monitors were exactly what they always were. The scrub nurse handed Nina her instruments with the brisk efficiency of someone who has performed this ritual 1,000 times and expects today to be number 1001. Peter Vane was already gloved. He looked at Nina when she entered and said nothing. She took her position. The first incision was made at 9:58 in the morning. For the next 56 minutes, the case moved with the controlled precision of any serious cardiothoracic procedure. Vane led. He was deliberate and quiet, the kind of surgeon who makes large things look like small things, not because the large things have gotten smaller, but because he has practiced the appearance of calm so long, it has become indistinguishable from the real thing. Nina assisted without being asked twice for anything. She anticipated. She watched the field with the attention of someone who has studied this specific anatomy for 4 pages and a parking garage and 8 months of accumulated footnotes. At minute 94, Peter Vane found what the imaging had not shown. The anomaly was worse than any of them had prepared for. There was a secondary vessel branching off the left coronary, at an angle so acute, it had been invisible on every scan. It was narrow enough that the imaging software had read it as shadow rather than structure. It sat directly across the intended access route, like something placed there on purpose to make the case impossible. The table went quiet. Not the kind of quiet that comes from people having nothing to say. The kind that comes from people doing calculations in their heads and not liking the answers they keep arriving at. The perfusionist said the bypass window in a voice that was technically calm. One of the attending surgeons said a number. Peter Vane looked at the field and said nothing. 20 seconds passed. 30. The monitor at the head of the table showed Arthur Pell's heart working at the edge of what a heart is willing to do under these circumstances, which is to say, it was working, and it was angry about it, and it was not going to be patient much longer. Nina Lawson said, "The modified posterior approach. Oblique entry. Left of the bifurcation. We have a window if we go now." She said it clearly, not loudly, not with her hands shaking, just clearly, the way you say a thing you have already decided is true. Nobody moved. She said, "Now." Peter Vane looked at her. 2 seconds. Then he stepped left and gave her the field. The window lasted 38 seconds. She used 31 of them, and the monitor at the head of the table, which had gone flat at 11:43 in the morning while everyone stood still, found its line again at 11:44. It held. Nobody spoke. Nina Lawson looked at the monitors and then looked back at the field, and her hands were steady, and her breathing was even, and somewhere on the 3rd floor a woman named Carol Pell was still holding a paper cup of cold coffee with both hands, watching a door, and her husband's heart was beating. It kept beating. The close took another 40 minutes. It was quiet work, careful work, the kind of work that good surgeons do well because they have trained themselves to be precise, even when the adrenaline wants them to rush. Nina assisted. She handed instruments without being asked for them. She watched the field. When it was done, when the last suture was in, and the draping came down, and the monitors showed Arthur Pell moving in the stable, steady way of someone who has been very close to the edge of something, and has come back. Peter Vane stepped away from the table. He went to the scrub area. He turned on the water. He washed his hands for a very long time, the way a person washes something when they are not thinking about washing it, when their hands are moving on their own, while their mind is somewhere else entirely. He looked at the tile wall in front of him. He did not look at anyone. He did not say anything. The attending who had sent 4 handwritten pages to the chief without a name on them was also in the scrub area. He was looking at his own hands. The silence in that room was not the same silence that had fallen over the operating table when the monitor went flat. That silence had been fear. This silence was something else, the kind that settles after something has happened, that cannot be undone and does not need to be, the kind that has weight and texture and asks nothing of you except to stand in it for a moment and understand what it means. Nina Lawson dried her hands. She put her instruments where they belonged. She walked out of OR3 and stood in the hallway for a moment, not moving, not thinking anything in particular, just existing in a corridor that smelled like every other hospital corridor in the world, under fluorescent lights that hummed at the particular pitch they hum when you have not slept enough. Then she went to write her post-operative notes. They were very thorough. 3 days later, Arthur Pell was moved out of the ICU. His daughter Grace came in first and stood next to the bed for a long time without saying anything, just looking at him, the way people look at things they were afraid they were going to lose. Carol Pell sat in the chair beside him and held his hand. She did not let go of it for most of that day. Arthur told them he felt like himself again. He said this like it surprised him, like he had expected to come back as something slightly different, and was pleased to find the original was still in there. The nurses on his floor said he was the easiest patient in the wing. He asked every person who came into his room how they were doing, and he seemed to actually want to know the answer. On his 9th day in the hospital, someone brought him a bag of hard candy. He shared it with everyone on the floor. Nobody told him, in those early days, exactly what had happened in OR3. They told him the surgery had been complex and had gone well, which was accurate, and they told him he was going to recover fully, which was also accurate, and they left it at that. Carol asked the attending physician who came to speak with them whether it had been as serious as they had feared. The physician said yes, it had been serious, and that they were very lucky. Carol nodded and looked at her husband and agreed that they were. They were not told about the 6 days the file had sat on the board. They were not told about the attending who had walked out of the consultation room, or the second one who had predicted the outcome and gone on to his next case, or the third who had marked the file awaiting review and left it there. They were not told about a resident who had tilted an imaging printout at 45 degrees in a hallway and felt something nag at her that most people would have let go. They were not told about a parking garage at 2 in the morning, or a spiral notebook filled with handwriting so small it looked like code, or 4 pages sent to a chief surgeon without a name on them, or a blue marker adding a name to a schedule at 5:45 in the morning. They were not told any of that. They knew that their husband and father was alive, that his heart was beating, that he would go home and drive his route again and bring candy on Fridays, and know the names of every kid on the bus. That was the part that mattered. That was the part that was true. 11 days after he was admitted, Arthur Pell walked out of Hargrove Medical Center on his own feet, with Carol on his left and Grace on his right, both of them holding an arm, as though they had agreed beforehand that they were not going to trust gravity alone with this particular task. He stopped at the door and looked back at the building. He was not a sentimental man, by his own description. He was practical and steady, and he dealt with things as they came, and did not spend much time on the ones that had already passed. But he stood at the door for a moment and looked back, the way people do when they want to mark something, when they want their body to remember, even if their mind moves on. Then Grace said, "Dad, it is cold." And he laughed, and they walked to the car. 3 days after Arthur Pell left, Nina Lawson was called to the office of Peter Vane. She stood in the doorway. He did not tell her to sit. He looked at her the way someone looks at a thing they thought they understood, and are now revising, not critically, just precisely, the way you adjust the focus on something to see it more clearly. He said, "Where did you find that paper?" She told him. All of it. The footnote, the garage, the 2 in the morning, the paper with 11 citations in 17 years. He listened without interrupting. When she finished, he said, "I co-authored it." The room was quiet. She looked at him. He looked at her. Between them sat everything that did not need to be said, that he had not recognized his own methodology when it came back to him through 4 handwritten pages, that a resident had found in a parking garage what 3 attending surgeons had missed in conference rooms, that the man who drove a school bus and brought candy on Fridays had gone home because a 29-year-old woman had read a footnote and followed it all the way to the end. Peter Vane did not apologize. He did not explain what Dr. Marsh had done with those pages, or indicate that he was aware of it, or address it directly in any way. He simply sat in his chair and looked at her and was quiet. Then he said, "I am putting your name forward for the advanced fellowship. No ceremony, no speech. 1 sentence, the same way you state a fact." She said, "Thank you, sir." She meant it. He nodded. She left. The fellowship she was nominated for was one of the most competitive positions in the department. A 2-year advanced program that took 1 resident per cycle and put them directly into the upper tier of the surgical team. In the 11 years it had existed, no one in their 2nd year had ever been nominated. The previous youngest nominee had been a 4th year, with 2 published papers and a recommendation from a department head at another hospital. Nina was nominated by Peter Vane, with a letter that was 2 paragraphs long. Those who later read that letter said it was the most direct and specific commendation they had seen him write in 40 years of correspondence. He did not use adjectives where nouns would do. He described what she had done, exactly, and what it had meant, exactly, and then he stopped writing. It was enough. Dr. Clifford Marsh requested a transfer to a different department 4 months after the surgery. He said it was a matter of professional focus. He wanted to concentrate on a narrower specialty. The administration approved the transfer without comment. It was handled quietly, the way these things usually are. Nobody asked him directly why he was leaving. Nobody had to. Grace Pell applied to pre-med the following autumn. She told her advisor it was a decision she had made in a hospital waiting room, sitting next to her mother, watching a door. She did not know who specifically had saved her father's life. She knew someone had, when they did not have to, when the easier path was the one that had already been taken by 3 other people before them. She thought about that a lot. She still does. Arthur Pell sent a card to Hargrove Medical Center every December for years after that. He addressed them simply, to the surgical team of OR3, and he always wrote the same thing in his careful, unhurried handwriting, that he was well, that Grace was well, that Carol was well, that the route still ran on time, and that the kids still waited for Friday. He signed every one of them the same way. Just Arthur. He did not know the name of the person who had saved his life. He knew someone had thought about him, worked through the night over him, argued for him, and stood over his open chest with steady hands when everyone else had stepped back. He did not need to know more than that. Some people, when they think about what saved them, think of science, or skill, or luck, or some combination of all 3. Arthur Pell thought about it differently. He thought about it the way a bus driver thinks, practically and without drama. Someone had known the route when everyone else had said the road was closed, and they had driven it anyway. That was the whole story, as far as he was concerned. And he was not wrong.